that transverse ligament, its job is to do what? Right, so it keeps the odontoid, the dens, kind of in contact with the anterior arch of C1. Right, so it kind of runs across the posterior aspect of the dens. So how would we kind of engage the dens into that transverse ligament? Like what position of the head would we put them in order to get that transverse ligament to kind of push, the dens to push into the transverse ligament? Flexion, right? So in this case, we're going to actually use kind of anterior translation of the occiput. Remember, C1 always follows the occiput. Remember that rule? So if I translate the occiput forward, C1 is going to translate forward, and now the transverse ligament is going to come in contact with the dens. So you're looking for any number of things. It could be that you don't have a good end feel. It could be that you have some of those neurologic symptoms that we've been referring to. Because if that transverse ligament is in some way disrupted, or more commonly, if the dens is fractured, you're going to feel basically that segment moving into the spinal canal. So you're going to now kind of be getting these bilateral symptoms and neurologic related things, upper motor neuron type symptoms is essentially what you're going to get. Okay? So fairly easy to perform. I'm just going to basically hold the head with both of my hands here, and then I'm going to think about translating. So again, I'm taking this and I'm moving. Notice I'm not flexing. Right? I'm not flexing his head. I'm translating his head. Okay? So I'm kind of bringing it up, and I may hold it for a few seconds. Okay? With many of these, I'll engage the patient in conversation because sometimes they'll get dysarthria. They won't be able to communicate with you, or they'll have slurred speech and things of that nature if you've implicated that spinal cord. Sometimes you also have to put pressure on for a period of time. So it's not like I'm there and I'm done and then I move on, but you bring it up, you hold it for a period of time, you're talking with them. A lot of times I'll make eye contact, so I'm looking at their pupils. Is there any change in pupils, or any nystagmus, any diplopia, any ringing in their ears? And they answer simple yes and no questions, right? So I'm kind of making sure that I'm covering all the bases. Sometimes we miss subtle things that are occurring because we're not really paying attention when we do these. So again, it's not just doing it and then kind of moving on, but talk to the patient, look in their eyes, see what's going on as you're kind of going through.